Thank you for the introduction. So I'm Rosmaliah. I'm pharmacy in HKL. So basically, we have a group of pharmacists here. And just to tell you that from in terms of fall management, we have 2 pharmacists also, which is already credential, I believe so. Yep, certified. And as part of the fall prevention team. So for me, like I'm more involved in training activities for pharmacists who have special interest in geriatric care. So let me share with you a little bit what I know about management of medication. And in terms for this workshop, basically it's more towards falls in older person, and I try to include a little bit about what we are doing during the COVID-19 pandemic. Okay. So first of all, the first part, we need to understand the medication management first, right? Why we take medication, why we give medication to our patients, why we give medication to people who are needed, who have diseases, right? So the main reason is we want to improve the quality of life. That's all, right? However, if they are not well and they are taking multiple medications, especially elderly patient, okay, remembering to take the right medication at the right times can be very, very difficult. And especially when you have a more complex regime, insulins before medication, early in the morning, once weekly dosing or once monthly patch, and so on and so forth. So if the medication aren't taken properly, the quality of life does not improve. And in many cases, actually, their quality of life are declines. So this picture is just to show you the complicated problems, right? If most of the time you encounter like more than one comorbid: stroke, depression, Parkinson, COAD, ischemic heart disease, hypertension, and so on and so forth. And which is diseases, of course, they end up with multiple drug use, what we used to call polypharmacy. As easy as you can define as using four or more than 5 drugs per day. However, when you have actually chronic illnesses, even who already reported, people who had chronic illnesses, approximately 50% will not take the medication as prescribed. So what happened to the list of medication that will be given to the patient? And you have to remember that drugs won't work in patients who don't take them. If you don't really criticize, analyze whether they really adhere to whatever that you prescribe, then you end up with adding on another drugs, and the cascade won't be stopped. So that is why we try to introduce what we call as medication management, which is mainly to assist in getting the right prescription to the right individuals and to ensure they are taken at the right time. But it's not only that. There are a whole lot more about medication management. Okay, we with the aim of like we want to make sure all the medication is given on time, all the time, and the most important thing, beside ensure the efficacy, we want to avoid the dangers of incorrect medication administration. So as you look at the pictures on the left side, is actually the poly pills, but the things will be getting more complicated if your patient need to be administered to NG tube. Have you ever like really look at whether the drugs should be crushed together and administered together through the NG tube? Each drug actually has different properties in terms of safety. By right, you should administer one by one. So just imagine you end up with 8 medications at the same time. So the things will getting more complicated. So medication management services, if you have at your own place, if you try to empower all your healthcare provider to make sure that you have a proper medication management services, actually you can improve patient use and administrations. You can improve in terms of percentage of patient meeting their health care goals, because if you give medication, basically you want to aim something, avoid in terms of cardiovascular event and so on and so forth, right? Reduce side effect and duplication, definitely. As you can see, the previous slide, I showed you the different comorbids. The most challenging part in Malaysia, if you have more comorbids, you are visiting at different clinics, and different clinics we still haven't have the integrated system whereby you can see the whole list of medication given to the patients. So you end up with duplication, different dosing regime, different dose, different drugs, maybe sometimes same drugs with different dose, okay? And of course, this will lead drug interaction from all the medication. So the subsequently is that most of the time it end up with adverse drug event, and this will cause increase the medical costs, right? For example, like they visit emergency more frequently. This will lead also to hospitalization. You can read, there are so many literature saying that the use of medication or polypharmacy among elderly will lead, has a higher percentage of causing hospitalization. At the same time, if you have a medication management services, you actually making the caretaker or a patient feeling much better and less stressed in terms of managing their medication. So what we want is not on the left side of the slides, not how they give medication in a one plastic bag, just dump like that. But if you can't really reduce the number of medication, at least it must be properly managed, as you can see from the right hand side. But actually, this is the result of polypharmacy. So the just to tell you some important data, okay, which is back in 2013. This is our local data. For elderly patients who are aged 60 and above, they actually visit our healthcare facilities about 6.1 times per year. And 67% actually visiting our public outpatient clinic with, of course, we have the elderly patient have higher number of admission, 157 admission per 1,000 patient as compared to a normal adult, 86 only admission per 1,000 population, sorry. And of course, they are always end up with a longer length of stay, and this number of patients basically use our public hospital, percentage of them, a higher percentage of them actually using our public health hospital. So you know the problems already, you know you need to have a medication management service, but you need to know what are you going to manage, right? Okay. So what I want to introduce in terms for this workshop basically is about, we try to put medication management, we try to introduce proper medication management service so that you can manage manage properly for when you use a potentially inappropriate medication, because this potentially inappropriate medication always end up with adverse drug event. Okay, so in this slide, actually, I just want to show you when you use potentially inappropriate medication, which is usually result from polypharmacy, it always subsequently leads to drug interaction, adverse drug event. Some patient may be not adhere to the treatment, and we thought treatment is failed. So sometimes patient presented with new symptoms. So most of the time, if you're not aware of, you might end up with prescribing cascade. You are treating the symptoms with another drugs, and treatment may fail, you overprescribe, you end up with multiple follow-up, and you don't really reconcile. When you talk about medication management, you can't really run from the terms of medication reconciliation. When you fail to reconcile...
Sorry, excuse me, we can't see your slide, Malia.
Is it?
Sorry, no, we can see your slide. Don't worry, Rose. Actually, if those people who cannot see the slides, can you please go to people, go to the top right-hand side of your screen, okay? Click on people, and then if you scroll to Rosmaliah presentation and pin that presentation, then you should be able to see the slide, okay? Yeah, so do carry on, Rosmaliah.
Okay, good, okay. So, if you fail to reconcile, of course, the circle will not stop. Okay, so in this workshop, of course, our concern is one of the geriatric giants, which is falls. So 1 of 5 falls, actually, according to the CDC, can cause a serious injury such as broken bones or head injury. So of course, this will actually lead to prolonged hospitalization and so on and so forth. So let me just quick ask a question. So what actually risk factor that you know about fall? What are the risk factors of fall? You can just start, or you can just say through the meet. Anyone knows how actually you classify the risk factor of falls? Anyone to say anything? Okay, I just quick. All right. So basically, when you talk about falls, actually it divided into two lah: intrinsic factor and extrinsic factor. So you can read some of the difference. Some say it's an extrinsic factor because drugs can be modifiable, but some say it's intrinsic factor. But for here, we put drugs under intrinsic factor because it actually change your internal physiological function. So what we need to aware of that when you give a treatment, you must make sure patient adhere, right? Then only you can achieve the outcome. But the problem is that what you want to manage here, if you use PIMS, especially when you use for risk increasing drug, and the problem is that when you increase adherence, sometimes the outcomes is actually 2.8 times likely to fall. So that is what we're trying to introduce here. We want to manage FRITS, okay? So have you ever encountered what is FRITS, for risk increasing drugs? Do you know anything about FRITS? Anyone want to list down or just say it out? What are FRITS? Farah? Amma? Amma, can you just name FRITS?
Antihypertensive.
Yes, amlodipine, CCB, any antihypertensive, correct? Opioids, NSAID, yes, so on and so forth. So on and so forth. So these are some of the lists that you sorry. If you look through FRITS, okay, these are some of the drugs is classified as for risk increasing drug. So if you encounter any polypharmacy with this list of drugs, these are the things that you really need to take note and try to either de-prescribe or review and try to adjust accordingly. For example, hypnotic, anxiolytic, tricyclic antidepressant, definitely no, especially in elderly patient, listed as potentially inappropriate medication since the first Beers criteria. Antipsychotic, benzodiazepine, SSRI, antihypertensive, and opioid. Apart from that, what I want to introduce is about anticholinergic burden. So actually, what has been reported that a drugs itself, actually the cumulative point when you use anticholinergic drugs, actually it associated with recurrent falls, all right? But an overall use of high level of anticholinergic drugs, such as very strong anticholinergic drugs such as antipsychotic, was associated with greater risk of fracture and no use in elderly adults with depression. So this is a list of strong anticholinergic drug listed in Beers list. If you are not aware of, Beers is one of the tools that you can refer to that lists down your potentially inappropriate medication when you want to review your medication, such as antihistamine, anti-Parkinson, and antipsychotic. So this is the simple way that I always introduce to my trainee. You can always download the website. It called as anticholinergic burden calculator. If you look at the left side, the ECB, when you, for example, if you put ranitidine, olanzapine, and metoprolol, the total burden is actually 5. So it has a higher risk of confusion, falls, and death. But if you try to modify, if you know the drugs and you know the alternative, basically you actually can modify the burden and reduce the burden. For example, ranitidine can use PPI if it's really indicated. Olanzapine, you may use risperidone, and instead of using metoprolol, you can use bisoprolol. So you end up you have a total score of 1, right? So this is one of the way when you want to review your when you want to manage your anticholinergic drugs. So apart from that, these are one of a systematic review that saying what are the risk factor and risk assessment tools. You can read through it, quite an old paper, but what I want to show you is that even though the prescription that having sedative and synoptic drugs, and most of the time these drugs are under antihistamine, antipsychotic group. So if a patient have a gait instability, you add on a CNS drug, you actually increase the risk of fall of a patient to a much higher risk, okay? Okay, another thing is that another paper, a risk factor for fall occurrence in hospitalized inpatient adults patient, colored in red. Actually, when you use the number of medication actually administered within 72 hours, within 3 days prior to fall, actually the odds is actually up to 1.2. Okay, so despite confusion, disorientation, you add on another drugs to manage your delirium. Actually, you are increase the risk of fall into another 1.2. Okay, why this thing happen? Why elderly? Why not in normal? Of course, adult they are also at risk of fall, but for elderly, the specifically why they are more prone to have this problem is that the basic rule of thumb is that their body change, the kinetics and the dynamics of their body change from the point of the medication reach to the patient. For example, if you want to give a patient um, olanzapine, for example, if it reach to a patient and patient swallow it, then only you can see the clinical outcome. However, to reach that clinical outcome, there are a lot of things happen in their body. For example, if you choose diazepam to calm a patient, and diazepam is classified as a long-acting benzodiazepines. They have more these long-acting benzodiazepine usually have a characteristic of lipophilic drugs, and in elderly they have more fats in their body. So all these lipophilic drugs tends to stay in their body longer. So the effects of the drug is much prolonged. Okay, so that is why patient become more drowsy, and sometimes they cognitively can be they can be more confused and so on and so forth. So that is why we need to aware of that the kinetics of the drug and the kinetics and the dynamics in the patient physiological body actually change. So you need to aware that there are more tendency for them to have adverse drug event as compared to a younger people. So now we come again to medication management, right? Okay, so what we want to introduce in your healthcare facilities or everywhere, even if you are at Ministry of in education level, try to incorporate the importance of pharmacists. If you are in to be part of the fall prevention team, okay, because we believe that clinical pharmacists or any pharmacist should involve in fall prevention strategies, no matter it's either inpatient or outpatient. They need to know how to screen for risks. They need also, even though they are not the main person who are doing the screening, but they need to know that how they screen for risks. So what is high risk, what is low risk. If a high risk, then you need to review medication. You try to optimize the medication, try to minimize the polypharmacy and manage the adverse event. And clinical pharmacists, definitely you cannot work alone. You have to collaborate with the physician, all right? So that to consider which frisks can be stopped, switched, or reduced, all right? And it's always multifactorial intervention. It's never that only drugs causing fall. It's always the other things. And some frisks, we really don't have any alternative. So how we could manage the problem. And any action that been taken to either prescribe the drug, it must be documented properly and must be conveyed to a relevant healthcare professional. As I mentioned just now, multiple comorbidities, multiple clinic follow-up. So you can't just document at your site. How are you going to deliver the drug that you have been properly managed just now to another level of care? We always say about transition of care, how you manage this problem of transition of care. And education must be also provided to the caregivers and the older person, because it can't be only the healthcare provider, it must be also involve the patients. So just a brief, in short, medication reconciliation. Because I want everybody know about medication reconciliation. It's just not about taking medication history. It's about a process of creating the most accurate list. Because it's just based on okay, the usual care is that when a patient admitted, for example, if patient hospitalized, we always look at prescription. Okay, we only based on one source. Sometimes you refer to the patient or medication, the medication that they brought in to the hospital. So by right, actually, you need to get a few resources. You have to talk to the patient, interview patient, from the list of medication, from the medication record, then only you can transfer or discharge order, definitely, and provide the medication, a correct medication to the patient at all transition point. And you need to address a discrepancy. This is all about medication reconciliation. It's always a 4-step. Collect the history, compare, correct, communicate, and that is about medication reconciliation. If you just collect, it's not enough. Okay, you haven't done the medication reconciliation process. So why is it important? The most important about taking a good medication history is about you want to avoid differences, or you want to avoid medication discrepancies. You want to make sure that if there is a difference between drugs treatment, either dose, route, or frequency during transition of care, it must be documented properly so that it won't be any discrepancy. I just want to share with you, there's one case whereby we encountered one patient discharged from our hospital, and then we stopped their metformin because patient had frequent hypoglycemia, fall, very frail, cacat sick, and then end up discharged. But unfortunately, the person who actually taking care of the patient is actually a different family members. So that the message was not really conveyed to that particular family members. She's the one actually who taking care of patient at home. So end up her daughter brought her to a clinic kesihatan, her usual care, the nearest usual care. Then they add on back a metformin because it was not documented why we stopped the metformin. All right, so this is one of a discrepancy that we do not want to happen. Okay, so when you talk about discrepancy, it's always intentional and intentional. It's not always wrong. If you have a tendency to do a discrepancy and intentionally, there's nothing wrong with that as long as you documented. But the one that we don't want to happen is unintentional discrepancy, accidentally made by prescriber, and or due to lack of documentation in the clinical record. So the only way to minimize a discrepancy is by doing a formal medication reconciliation at every point of care. So just want to share with you, these are the medication discrepancy study done in our Malaysia. All right, very old study. About 49% adult, discharged from hospital had medication discrepancy. 25.17% medication error were detected among 1,600 prescription geriatric received in teaching hospital in Malaysia. And the last one in black box, actually, the one that we are doing in our setting, we found out that 65.3% discharged patient had discrepancy, but with 22.6% were actually unintentional. Okay, so try to encourage as much as possible a proper way to do a medication reconciliation. So always if at hospital or during hospitalization, upon admission, you always should encourage to take a best possible medication history, but it never end up with one-man show. Of course, during hospitalization, the doctor will clock the patient and then admitted. If the ward has ward pharmacist, you should refer to the clocking history by the pharmacist when they check the medication, because we have been trained to get a proper medication history. And then sometimes maybe family members come in, they're telling the nurses, we have this drug, so we can add on, then only you can end up with a best possible medication history. Okay, these are an example, because these are the examples of medication of a patient. Okay, you can see that actually this patient had multiple follow-up, all right, and about almost 20 medication, all right. And what happened is that from the clocking notes, it's actually about 13 drugs being documented. This is 72 years old with multiple hospital admission, coming in with delirium, memory assessment was done, hypercalcemia, low BP, and history of fall. So this is how we end up with the medication list. We actually identified another 7 other drugs, and apparently, if you can see from the star, there's a polypharmacy there, calcium carbonate and calcium lactate, trimetazidine, fenofibrate, and ranitidine, which actually this patient had a CKD. If you calculate the HFR, actually you need to adjust the dose of the Vastarel, fenofibrate, and ranitidine. On top of that, patient also had prazosin, which also high risk of fall, and also insulin. All right. So during the inpatient stay, okay, that is how when you take the medication history at the point of care. And then during the hospital stay, you can't stop there. You always need to always reconcile and check for any discrepancies. All right. If it is not been started yet, it's okay. But upon discharge, reconcile again document and communicate for any medication that you plan to stop, add or correct, right? Communicate with the prescriber and always try your best to simplify the regime, document and transfer the information. So this is in short about medication appropriateness index when you want to simplify a medication regime for elderly patient. There's a 10 question there. You can check whether each drug you can criticize, indicated, effective or not, dosage is correct, whether the direction is good, practical, is there any drug-drug interaction, drug disease, duplication, duration, of course, is there any more cheaper or less expensive alternative. For example, look at this chart. At 6:30, patient need to take some medication, 7:30, 8 o'clock, 1 noon, 2 p.m. and so forth. So it's very complicated. But that's the best that you can do because these are the least simplified regime. But by the times come, you need to try to give prescribed or optimize to the least medication so that it will reduce harm. Because always remember, taking more medication and a complicated drug regime always end up with non-adherence, right? So this is just to share with you a picture of during our clinic session. It's a bag of medication that we need to reconcile because patient had multiple follow-up, multiple fall, right? So we all after reconciliation, we always need to review. Review means clinically compared with the clinical condition, especially when you talk about falls. Okay, focus on falls and fall-related injury with a goal of reducing, altering, or eliminating medication that increase risk of fall. And also as outpatient, also you can always educate and counsel patient and caretaker when there's a change of medication or if you can't change any of the medication. And always actively involved in conducting consumer education campaign and awareness activity. So in short, basically whatever you are doing after reconciliation, it must be appropriate, communicate, documented and dated, right? And always know when you know the reason why you stop, why you start or why you change the medication. And the last part is that healthcare is always team effort. Sometimes you have a very good team effort, but you forgot to involve the patient because the patient is always a team player or the caretaker is always a team player. And we all need to do what we can to help them succeed. Okay, so the last part is actually talking about COVID-19. So that is what happened when you talk about medication management. But when in during COVID-19 pandemic, unfortunately, there's a lot of things changes. We need to readjust our human resource. Like for example, like my friend in Sungai Buloh, totally become a COVID hospital. So what happened to the service there? Okay, so just to tell you in short, the usual available medication management services that we have in some of the hospital with geriatric services, we have ward pharmacy services, we have home medication review, home visit, or what we call now is pharmacy home care service. We have the geriatric medication therapy adherence clinic, and we also have actively involved in training and teaching, either external or internal. So what happens, some of the services definitely we need to withhold, such as training at the beginning of the COVID pandemic. Some of the services which is not appropriate, we need to stop, such as home medication review, some system, what we call a system pendispensam berpadu, whereby we deliver a medication to another healthcare facilities. But some services will still remain the same because even though you have a COVID-19 patient, you still have the non-COVID patient admitted, right? Because as you know, elderly patient has high risk, high chances of getting hospitalized at any point of time, especially when they have comorbid. So these are some pictures, like my pharmacist during the medication reconciliation. You can see that plastic of bags there and medication, like this patient is actually 80 years old. We are not sure why there's a big bunch of medication still there. So you need to reconcile and review. And on the right hand side, we still need to continue bedside counselling to ensure patient understanding. And these are also some other, for examples, when we're doing reconciliation, there's a lot of medications and lots of balance, even though the appointment is actually almost at the end. All right. And sometimes we need not only one, we need two pharmacists to reconcile the medication, right? Just to make sure that when we remove a medication, we always have a double check with another person. Apart from that is also just to let you know, I think some of the, like if you look at Australia, they have the medication was supplied by a community pharmacist. But here, if you are using the hospital pharmacy service, we the government hospital pharmacy service, we have value added service. What we call, for example, like ubat melalui pos, whereby we post the medication, including in UM, they also have a delivery for cold chain medication. Like some hospital, for cold chain drug, we can't really post, we ask them for drive-through. But it's good that UM actually have the cold chain medication delivery. Is some drive-through, I think throughout Malaysia, we promoting the drive-through pharmacy service to make sure that patients get their medication on time when we extend the follow-up. In Sungai Buloh, they still continue their service by use the teleconference visit. It's not to replace the usual visit. It's just to make sure that when they postpone the TCA, patient is actually still in a good condition, or to make sure that patient who are have hospitalization, we can reconcile at that point of time, or if needed, we call back the patient to our hospital. And now things are getting better. We are starting back our clinics, even though the last time we hold it, right? And yeah, so I think that's the end of the slide. There will be more changes actually. Yep. That's all about it. Yeah. Okay, Prof Tan, I think I finished my presentation. So, any question? We have like another 21 minutes. Sorry, 11 minutes before we end the session. Any question? Yeah, Prof Tan, I'm on time.
You have kept beautifully to time. Yeah, I think. Well, if while people pluck up the courage to contribute and things like that, yeah, I mean, from a personal point of view, when I try and change someone's medication, cannot change one because you know, like I see lots of patients with antihypertensives that they don't need. The blood pressure standing up is 90 systolic, but they still will not stop that aspirin, and they will not stop that atenolol that some dato who's a cardiologist has started, and I obviously don't have the dato-ship, so I do not have the power to stop. Yeah, how do you deal with something like that, Malia?
So yes, it's true. Actually, it happens. Sometimes it's very difficult to really de-prescribe. So what the best thing that we can do, we try to convince them. For example, if actually it's really indicated, then no choice. We have to counsel them. For example, let's say there is no alternative, safer alternative, then we just tell them that here's your medication. There's a risk of using this medication, for example, at any point of time. For example, if you are not in a good health, it may cause your BP drop. For example, you're not eating well, so you need to be more careful, close monitoring, make sure your family members is there, and so on and so forth. If you're still not feeling well, you can always consult to any nearby clinic, or you can call us any point of time. So that's the best that we can do. Yeah, because it's not really, it's simple. It's very simple to say that you can de-prescribe, you can stop the medication, but actually in reality, it's not. Yeah.
Yeah. Rosalind, do you have a question? Do you want to unmute yourself and ask the question?
Hi, Malia. Thank you very much for the very informative talk. But I just want to know the medication management services. Is it only in HKL? What about district hospitals and other government hospitals? Do you know the
Actually, medication management is just like common terms. But as I mentioned just now, there's a lot of services that provided in other hospital. So if I talk about geriatric per se, in any hospital with geriatric unit or geriatric team, most of them either they have the home medication review, or they have the medication therapy adherent clinic, whereby you have pharmacies together, or they have ward pharmacy. Most of the hospital, we do have ward pharmacy services, but not all have all the services. HKL is actually the training center. But we are getting more and more hospital to have all the services, because I would say it's not easy to have all the team together, but I think we are on right track. So other than that, in terms at least at district hospital or at least at district primary care, they do have what we call as home medication review. Maybe sometimes it's related to diabetes medication management. Most of the time is diabetes medication management, but they do really also look at elderly people. So it's just that maybe they are not in a multidisciplinary team, maybe the pharmacist alone. So I would really encourage, if you know your pharmacist at your place, try to make them as part of your home care team. Because almost all the KK, actually they have a home care team, but we are not incorporating. So that is what we are trying to promote now, pharmacists to be part of the home care team. Did I answer?
Thank you.
Yeah.
Yep, you did. Thank you very much.
Just you need to bear it a bit. It may take time, but I think I'm gathering almost like I think we have many pharmacists in our SIG group. They are really enthusiastic. They want to know how they can do the home medication review, how they can get training. Get training is something like something bonus, but actually we can always teach them how to do by times lah. So maybe in 2030, I believe, when we become a really aging country, we have all that at all level of care.
That's so positive. Really nice to hear that, Mania.
So,
I mean, that's all we can do. We can't just say, "Oh no, we don't have anything so terrible." We just kind of, it matters. It matters to the one who got it. That's all we can say. So, Kamalak, you have quite a long question there. Do you want to unmute yourself and ask your question? Would that be?
Sorry, I didn't see the question.
Yeah. Kamalak?
Most of the elderly patients, there are so many medication, they tend to get dizziness. How can we avoid this? Most elderly patients, they have balancing problems, they suffer from vertigo. How do you avoid all this? Okay, actually, I always believe this. Any symptoms is actually related to drugs, adverse event, until you've proven otherwise. Okay, because as I mentioned, their body change. Whatever that they took at age 40, and if they continue the same thing at age 80, definitely it causes different effect. Okay, so you always need to review back the indication whether it's needed or consider a safer alternative. We must do that. Most of the time we thought like, okay lah, patient is okay, what? Been taking since 40 years ago, why I need to stop this thing? Dizziness and vertigo is very, very common. They always complain of that. But we always said that, alah, you tak cukup minum, you tak cukup makan, you are not eating enough, or maybe it's just because of you just malnutrition, something like that. It's true, but it can be concomitantly effect of the use of medication. So you need to prove it's not related to your medication. You need to prove that. Okay.
That's so refreshing. As somebody who actually speaks sense. Could you imagine? I will ring the neurologist and says, it's your Medopa that's making my patient confused, and you fall over. No, it's not my medication. My medication has no side effects. Yeah. So it is really refreshing to hear that, and I totally agree with that. It's a drug until proven otherwise. We're happy to stop even all the drugs and start again.
Right.
The symptoms are troublesome, but it's really tough. Yeah.
Yes, it's really tough. For example, like patient had ischemic heart disease. Yeah. Have you ever really think like you want to adjust the Vastarel dose when the GFR is around 30 to 60? By right, you use OD dosing, but we always end up patient with BD dosing even though the GFR is like 30, 15, because we forgot to review back. There's a study said by right you should review the medication at least every 3 months. Or if you have history of hospitalization or frequent visit, you need to recheck back. Because most of the time, our elderly patient, the follow-up is very long, 4, 6 months, even up to 1 year. So they forgot to do medication checkup. They just remember to do health checkup, but not medication checkup.
Yeah, I've been on a mission to remove Vastarel from the formulary. It's very hard to put things in the formulary, but you can't take it out of the formulary because Vastrel actually has extra pyramidal side effects as
Correct.
well.
Yes.
Yeah, and causes involuntary movement. And then when I
Yep.
challenged the cardiologist to ask them why they choose Vastrel, because there's not really as much evidence as a lot of the other cardiac drugs, they went, I'm not sure what Vastrel is for and how it acts. So when I tried to take it off the formulary, it cannot be taken off. Once it's on, it cannot be taken off. Yes. Yeah, so it's really strange. Yeah.
Yeah, I agree. I think because compared to Vastrel and Index, I think people are more convinced to use Vastrel compared to Index, because Index like causing headache or BP drop much more severe compared to Vastrel, right? Like when you talk about Vastrel, you didn't think of like posture drop, you didn't think of extrapyramidal effect. They won't think about that. They just think at Index, the BP can drop, the heart rate can be reduced. So better use Vastrel for angina instead of like Index. So I think that's why they don't want to remove from formulary. Probably as simple as like when I asked not to use statin together with not to use simvastatin together with amlodipine. So have you ever like tried to de-prescribe or consider bad when you use amlodipine with simvastatin? You should not use more than 20 milligram because there's a drug interaction. But people will telling me, patient has been ongoing using statin and amlodipine for the rest of their life. It's okay, what? But just check back. Have you ever asked whether the patient becomes sick after they're taking this? Or when they become old, the effect of the drug is much more severe as compared to when they were taking at age of 40. So it's not really easy to convince people to de-prescribe actually. Yeah,
it's tough because actually amlodipine also has a lot of side effects, and it's basically the prime drug for us for what we call cascade prescribing, because amlodipine causes leg swelling because it's a peripheral vasodilator, and then they will end up on a diuretic to reduce the leg swelling. It causes it actually causes constipation, and then they will end up on
BPH medication. Laxative. Even AUR also.
Yeah, and then it causes a headache, it causes headaches. And then they will end up on, don't know what kind of migraine treatment for headaches. Yeah, so it's quite interesting because people actually think amlodipine has no side effects. Yeah. And it's a drug-drug interaction too. Yeah.
Right.
So, okay, we've got some comments here. Okay, so Ija A. Yeah, do you want to unmute yourself and ask a question yourself?
Good morning, Assalamualaikum. Can you hear me?
Yeah.
Yes.
Okay, so my brother is a pharmacist working in Hospital Kuala Pilah, and actually is interested in geri pharmacy because he enjoys doing medication review, and he has this idea of going for home visits and things like that. But do you have any advice for interested pharmacists in terms of training, career path, and expectations?
Okay.
Thank you.
So thank you for the question. So actually, what we have now is that we have a training pathway whereby if you have interest in doing geriatric training, you just apply. You just give me a call also can. All right, because basically you just need to contact the training center, which is currently we only have Hospital Kuala Lumpur. We are working up for actually Sungai Buloh and Taiping for a training center, hopefully. So just contact if you are government hospital from government setting, you just contact the training center, confirm with the date whether you want to do a training or not. Then subsequently followed by a letter to our pengarah, to our director of hospital that you want to come for training. And then there will be about 2 weeks training, full training, 18 hours basically. And then there's a logbook that you need to fill up. Once completed and you pass the pre-post test, you'll be given a certification. And then if you want to be credentialed, by right, you need to actively involve in any geriatric activities, either a ward, MTech, and home visit. Definitely the best is involved in all those 3. You need to show some contributions. And then after 1 year, you can apply for credentialing towards our Amalan and Perkembangan Pharmacy lah, the development and training unit at our HQ. Then until now, it's up to that. We are working on the SMA pathway, we haven't have it yet on place, but we are working on it. Hopefully, so at the same time, you need to always continuously update yourself by joining all the CNE, try to certify yourself with other certification. Then I hope, and of course, you need to practice lah. Certificate is not enough. You need to continue practice it, right? Yeah. So if anything, you can always PM me if you want to know in details. But how to apply actually is available online. You can just Google up from our Bahagian Perkhidmatan Pharmacy website. There's a guideline how to apply for training. Okay, Ija, Miss Ija. And it will be good if you have a lot of district hospital actually.
Yeah, so yeah, because this was one of the thing, because when he's in district, he realized that these are the like people who live in their own house, and
Right.
the level of care is not really good,
Yeah.
especially when it comes to medication, because they have to travel far to the town and get their medication, and then when they are at home, pandai-pandai sendiri lah kan. So it's actually quite a lost opportunity for them. So he's interested in doing that.
Even actually, I do admit sometimes we still don't have everything in place yet, as compared to if you go to Australia, everything is in place. You can just go to anywhere of their community pharmacy. Most of the pharmacy been certified to do HMR or anything. But here, even at this level of at this point of care, I even give my personal number because I don't know where to refer to, because they are so far away. They don't know where to ask, right? I also even don't know who to contact with, because I know in KK especially, the pharmacist is just even like one or two. They have the other things to do. So if I add on another burden, it will be like troublesome for them. So at this point of time, I do admit we don't really have everything in place yet, but we are on the right track. Yeah.
Okay, terima kasih. Thank you.
Okay. Dr. Kamalak said, we GPs give Fasteral for dizziness and vertigo. If patient has got Parkinsonism, we don't give Fasteral. Thank you very much.
Yay!
Yeah.
Please spread the important point about Fasteral among your GPs.
Yeah, somebody actually knows there's actually extrapyramidal side effects. Okay,
Yeah.
so it's now past 12:30.
Yes.
So thank you very much, everyone. It's been a fantastic moment.